Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor. I'm here this evening with my co-host Jim York.
Thank you.
And this is a show where we talk to and interview, but really we're educated by our local specialists. And tonight we have Dr. Marc Guttman, who's a practicing gastroenterologist. And I'm sorry, that's not, we just got finished doing that. That's my apology. A practicing urologist in Naples, Florida. And we're going to be talking about prostate cancer, the whole subject.
Dr. Guttman, before we go into this, I know you've been on the show before, but just give us a little background about yourself and
Sure.
You know, where you're located. And
Absolutely. So this is my third year in Naples. I came from Philadelphia, is where the bulk of my training was. New York before that. I've pretty much spent the past 3 years in Naples, and it's been great. We have 3 offices. Downtown Naples, we have one in Marc Island and one in East Naples. So we try to be spread out, so we drive so you don't have to, and try to make it easy for patients to get to us.
I guess we're going to talk about prostate cancer this evening. And
Yep, a little bit about screening. There's a lot of controversy about PSAs, and we'll go from there to a little bit about the newer things that are coming out.
Okay.
So pretty much PSA, screening for prostate cancer has been the screening for prostate cancer has been mainly a PSA blood test and then a rectal exam. As of, I'd say about 2011, there's been a lot of controversy regarding PSA screening, whether the blood test is good, whether it's a good cancer test or not, and there was a bunch of recommendations that have come down that have changed the way that we do things. The rectal exam, pretty much people still do, just because if you feel something, you need to get it checked out. But on the blood test side, the PSA blood test is not a very good cancer detection test. It's not a good test for finding cancer. It's very good. It's prostate specific, but it's not cancer specific. So pretty much the reflex that used to happen, the PSA bumps up, you get a biopsy, is not okay anymore. Now what we do is there's a lot of different reasons why your PSA can increase. One being just having a large prostate, having an inflamed prostate called prostatitis, and then cancer is the third of the big 3. The way that different people go through the algorithms is what dictates what we do. So pretty much if you have a big prostate, your PSA could be elevated, and it's called benign prostatic hypertrophy. For prostatitis, if you have an infection, you give a course of antibiotics and it decreases, your PSA goes back to normal. Great, that's an inflammatory event. If you have sex, if you have bike riding, motorcycle riding, anything that stimulates the prostate can make that number go up. And so for about 4 or 5 days before you get your blood test, you shouldn't interact in any of that stuff. Give your prostate a rest, get your blood test, and go from there so you get an accurate reading. The next level, there's a test called the PCA3, which we used to use for if people had negative biopsies and their PSAs were still going up, you say, do I have to really biopsy this guy again or not? And that was a test that got developed a while ago. It became, now it's a little bit more frequent to use it actually as a screening along with PSA. So what that means is it tests for amino acids and proteins, this PCA3 gene, that is elevated in prostate cancer patients. Okay, so if you're over a certain point, you have about a 40-50% chance of having a positive biopsy. That's a different test than PSA. That's more cancer specific rather than prostate specific. Other tests, there's a newer one.
Can I?
Sure.
I don't want to interrupt. I just want to go back to the PSA screening, because originally, I think there's still a controversy, and I just want to make that clear because patients are still confused, or maybe you could help us with that. PSA was originally a research tool to follow cancer. It wasn't necessarily, or was it a tool to screen for cancer in the beginning?
So in the beginning, no, it was absolutely, it's a test to follow. They didn't really know what to do with it when they found out there's something called a PSA. So what actually, it's still an accurate tumor marker, okay? So which means that if you diagnose the prostate cancer, you still want to use it to follow. For screening, to say, all right, every man in America needs to get a PSA, that's where the debate comes into play. So if you think about from PSA from the standpoint of, first of all, what's the function of PSA? It actually liquefies semen. So that's the part that if you leave semen out for 10 minutes, it'll turn into water. That's what PSA does, okay? So from the aspect of how do we use it for screening, it's, like I said, there's a lot of things that can really alter the PSA. The recommendations used to be you get one at 40, you get one at 45, and then every year after 50. Now, the recommendations, I follow the AUA recommendations, which are pretty much, you don't screen anyone under 40. If you have a strong family history or race is abnormal, then you need to start screening earlier. So 40 plus, you can get one at 40, 45, and then 50. Then for patients that have high risk, race, and then a father, a brother, uncles, or a son that has prostate cancer, you want to be a little more aggressive with screening there. But for the general population, they're recommending between 55 and 70 is when you should be doing the screening tests. Okay.
So it used to be, or at least I thought it was at 50. Now they've raised it to 55?
That's the AUA, yeah.
70?
That. Yeah, 55 to 70. That's where you get the greatest benefit from screening general population.
So a year or so ago, I remember that, I don't know if it was the AUA, but a body came out and said, don't do PSA testing anymore.
That's the USPSTF. So in 2011, they came out with a pretty much with a statement saying that they got a grade D recommendation. So that means that you shouldn't be doing it. The risks outweigh the benefits of doing the test. You have to study too many people. These are the same people that tried to take away mammograms a little while ago also. And I was at the AUA conference that following year, just a few months after that.
American Urologic
Association. And they had someone come from the USPSTF, and the New York Times headline the next day, I remember, said outrage at the AUA. Because the people, that from our standpoint, the PSA has been in place for about 30 plus years now. There's been a 30% reduction over that time in prostate cancer mortality. A study came out actually yesterday from, I believe it was Lancet, that said there was a study in 8 countries in Europe, 162,000 people were studied between the ages of 50 and 74. They said over 13 years, the reduction in prostate cancer deaths was 20%, and that's pretty good. That's a good reduction over and that's just over 13 years. So from what I think comes out of the USPSTF and all these different things is you just have to have a conversation as a primary doc. You have to have a conversation with your patient and say, do you want to know if you have prostate cancer? The people that you screen are people that have over 10 to 15 year life expectancy. People that, so you don't want to, if somebody doesn't have that 10 to 15 years, you don't want to screen them. You don't want to put them through any extra any biopsies or tests or anything else. And then you should just check and make sure that everything is.
So the body USP, what body? Preventative?
So that is, that's the preventive task force. So that's there's no urologist and there's no oncologist on that board. It's a bunch of voluntary physicians, and I think there's a nurse, there's a gynecologist, a primary care doctor, and they just go over all the studies and they run the numbers and they see, how many people do we have to check to save a life. So that's where they get their numbers.
So maybe that's a similar backlash to what we saw when 10 or 15 years ago, everybody was taking women off of hormones, which,
right.
And then it came back to.
It's so what, the problem is that you're missing the people that need to be found early. So the guys that are going to have the aggressive tumors that when they're 55 and, by the time they're 56, they'll be metastatic, those are the guys you want to catch early. And that's the people that are not getting screened. And that's the real problem here. So instead of, people presenting early and treating them early, you're getting them when they already have metastatic disease or something else going on, or their PSA's, over 20, and you're like, oh, by the way, you should probably get this checked. That's too late. So and that's really the fears are, okay, on the USPSTF side of it, the fears are that there's overdiagnosis and overtreatment. So biopsies aren't without any morbidity. There's the old numbers are like a 0.6% risk of infection, 0.1% risk of sepsis, which is low, and you have to, but 0.1%, if you're in that 0.1%, it's 100%, and then there's a 1% risk of urinary retention. So those are the major things. For without the the overtreatment side, there's risk of erection issues, there's risk of incontinence on treatment, for prostate cancer. So now the trend actually is, so there's different modules, okay, of doing it. So the way that I try to do it is I try to use these newer tests, the PCA3, things like that say, all right, you have a higher percentage of having a prostate cancer. Do you want to have it checked? Do you want to know what your percentage is if we do a biopsy and your PSA is
So a patient that I do send you patients. I suppose I have to say that, but not really. But if I have a patient with an elevated PSA and what appears to be a normal prostate exam, I send them to you. Then, so is that, what do you do then?
I don't reflexively just biopsy people. So my goal is to rule out anything silly. I try to rule out any prostatitis or any inflammatory. So I'll give them a couple weeks of antibiotics. That hasn't been shown to improve survival, but if I'm going to recheck a PSA, I want to make sure there's no lab error, anything like that. If I'm going to recheck it, I try a little intervention with not too much comorbidity. So I give them a couple weeks of antibiotics, and I check the PCA3 test, and then we go from there. You also want to look at velocity. So if you just have one PSA, it's different than having 4 or 5 years of them, and you see it slowly creeping up. Or if it goes up over a point over a year, if the PSA is over 4, or if it goes over 0.75, their PSA is under 4. There's also age-related changes. So if you're over 65, up from 50 to 65, 2.5 is the upper limit of normal. If you're over 65, it can go up to 4, and you can have a normal PSA for your age. So if you're looking at a 53-year-old with a PSA of 4, that's not good.
So for our viewers, can you tell them what velocity is? You said you look at velocity.
That's just the change in the PSA over time. So if it's abnormally high, then that's something else to check for, and we'll check a PCA3 then, see what the story is. Or if it and these things, that's just also for the patient to say, I have a concrete number here. I have a 50% risk, instead of just saying, you need a biopsy just based on these numbers. We have a different ways. Like I said, a more cancer-specific test than a prostate-specific test that's really telling us, what's going on here. There's other newer ones that are coming out also. When we go to these conferences, there's tons of companies that have them. There's another test called Prostate, which also is out there, and they test for amino acids that are elevated in prostate cancer patients. There's a lot of different things that are out there. So even patients that have had, my PSA has been high for years and years, and it just keeps on creeping up, and I've had 5 biopsies, I'm not worried about it anymore. Those people now, you can do MRIs on them and actually target the lesions. So we can actually take an MRI, put it on top of an ultrasound, and say this is where the lesion is. This is a suspicious site, and we put a needle right into it instead of just randomly sampling the prostate. And those are things that the tests are changing. The technology is changing and moving in the right direction. So from my standpoint, the fears are, like I said, overdiagnosis and overtreatment. So things that if we talk about overdiagnosis, overtreatment, what we should be doing is, instead of saying, we're not checking PSAs anymore, we're not going to look at what's going on from a screening perspective. We're just going to deal with the after effects. Instead of that, you just have to be more attentive to the other side of it and say, if we find it, I'm okay with following it as long as we know what's going on. And people should be pushing active surveillance instead of just treating everybody with a tiny little piece of low-grade cancer. And we have a lot more tools now than we used to have for that also. To say, all right, they're genetic tools. There are things that we can take the prostate tissue and we could see, this is a tumor that has been there probably for 10 years, and it's going to be there for another 20 years, and it's not going to change. This isn't something that we need to treat. A low-grade prostate cancer, that's just a low-grade prostate cancer that's always been there, versus one that, in 2 years, this is going to be an aggressive gleasonate lesion, and we just found it early. So these tests are coming out now. In breast cancer, they do have them, and it really dictates care. In prostate cancer, we're just coming out with them now, and there are a few of them out in the market that have been pretty good. And what they tell us is, this is an aggressive genetic profile. So if this is a Gleason 6, which is a low-grade cancer, and a teeny little bit of it, but this genetic profile is extremely aggressive, and in a few years this could be trouble. That's a person that you'd want to treat early, versus one that's on the lower aggressiveness scale. You can just watch them, and you can say, all right, we're just going to do a PSA every 3 to 4 months. We'll do a biopsy in a year, and then maybe 16 months after that, and really just watch it closely. And that's called active surveillance. So I think instead of them getting rid of screening, which is crazy, and from my standpoint and from a urologist standpoint, we should lean towards active surveillance and just not over-treat everybody that walks in the door.
Well, that seems pretty logical to me. We're going to take a short break, in just a few minutes, and we'll be back with Dr. Guttman to talk about prostate cancer screening, testing, treatment, and more.
When picking a realtor, don't just pick anyone. Pick someone with experience. Pick someone with a proven track record. Pick a realtor like Jim York from Downing Fry Realty, the #1 brokerage with the most real estate transactions in the area.
My husband and I had very specific ideas about what we wanted in our new home. Jim York was able to help us find the home that was ideal for us.
With over 20 years of real estate experience in Southwest Florida, Jim York has negotiated over $200 million in sales contracts. Selecting the right realtor is a critical decision that can earn you thousands when selling or save you thousands when buying.
Jim also helped us with a mortgage lender and a good real estate attorney. He went that extra mile, and his experience says it all.
Call Jim York for a no-obligation meeting at 239-273-6727 or visit his website, www.naplesyorkrealestate.com.
Welcome back to Dialogue with the Doctor. We're here this evening with Dr. Marc Guttman, and he is a practicing urologist. I called you a gastroenterologist at the beginning of the show, which I know you're not, in Naples. And we're talking about prostate cancer. We've been talking about prostate cancer screening with PSA and with the PCA testing. And we left off where you were talking about targeted biopsying. Can you, with something called URINAV, or can you tell us more about that?
Sure.
Because that's new for, I think, many of our
Absolutely.
viewers.
So for people that, you wouldn't do it on an initial biopsy, but for people that have had PSAs that were going up for a while and their numbers just keep on climbing and multiple negative biopsies, you get an MRI, you can pretty much see if there's something going on. That does not, people say, oh, can I just get the MRI and get treated? No, you need a tissue diagnosis to make sure that there's cancer there or not. Okay, just because you have a suspicious site in MRI does not mean there's cancer there. So the problem is, though, if you have a 1 centimeter lesion, it's a little difficult to catch that if you're just doing a random biopsy of a think of it this way: if you have an orange, okay, and you stick a needle into it 20 times, they're going to hit the seed. Those seedless oranges with one seed in them? Maybe not. You might, but you might not. But that's pretty much what you're doing here. You're splitting the prostate up into areas, and you're targeting different sites. This technology is something that is coming to be very, very, very at the forefront, very much at the forefront, and it's something that you get the MRI, you link it up with an ultrasound, you can target it, or you can even just say, hey, you know what? There's an area at this spot of the prostate. I'm going to do 3 biopsies from there instead of 1. And target that area and try to increase my chances of finding something if it's there. If it's not there, great. If you get an MRI and you say, all right, this is a lesion, and you biopsy and there's nothing there, then fine, you're okay. But you don't want to come back 5 years later with metastatic disease because you've been biopsied twice and nobody found anything. That day could have just been a bad shot, and that's it.
So when you find something, okay, what do you do? What is it that you find? How do you classify?
So there's a few different things. So there's low, intermediate, and high risk prostate cancer. Low risk prostate cancer is PSA 0 to 10 and Gleason 6. Intermediate grade is 10 to 20 on the PSA and Gleason 7. High grade is Gleason 8 and then 20 plus on the PSA. Okay, either or of those. So when we look at what we're going to do, we pretty much have to risk stratify first. Okay.
And the Gleason is how is that?
So Gleason score is it's 2 numbers that come in parentheses. So it's open parenthesis, first number, a plus sign, a second number, close parenthesis, and then a total. Okay. The way that you get the numbers is the first number, the first slot, is reserved for the bulk. So 51 to plus, where 60% of the piece that we took out has X type of cancer. So what it is we take if you take a needle, a hollow point needle, and you stick it into an apple and you take it out, you get a core of tissue, okay? That core is sent off to a pathologist. That's a doctor that looks under a microscope at the specimens and says, is there cancer here or not? When they do that, they line it up with a chart that goes from 1 to 5. 1 and 2 are not really diagnosed anymore very often. 3, 4, and 5 are low, intermediate, and high. Okay, and you get 2 of these numbers. So you get the bulk. So let's say 60% of it is a 3. The 3 goes first. Plus sign, and then the second, so the 30% of the tumor is a 4. The 4 goes second. Okay, and then you get a total number. All right, so now you have your full Gleason score is a 7.
So what you're
but
saying
a
is
3 plus 4 is better than a 4 plus 3. Okay, so you want the lower numbers along the entire thing. Okay, so if you have 2 3s, Gleason 6, 3 plus 3, that's low grade, and the whole thing is the lower grade. Okay, if you have a 4 in there, it seems like that tumor wants to be more. Wants to be a little bit more than it is right now, and it's something that we need to address really more than that. Once you get the Gleason score, that's the first part of stratification. If you have high-grade disease, you should get a bone scan and a CAT scan right away. Make sure that nothing got outside the prostate. Besides that, then after that, the next step is really, and a lot of people get them sooner than that also, but the recommendations are for high-grade disease. Once you're diagnosed and you have your staging complete, after that, I pretty much go through every step with the patient. I show them a PowerPoint with everything that's out there, and I go through from top to bottom what options are. So there's watchful waiting, which used to be the oh, don't worry about it approach. The problem is people weren't doing so well with it when you just say don't worry about it, and then they come back and they're having issues. So that's reserved really for the 90-year-old guy that you wait for metastatic disease, you wait for them to become symptomatic, and then you treat the symptoms. You're not there to treat the prostate. Okay, so that's what I reserve watchful waiting. It's had a paradigm shift in what we do. The next step is something called active surveillance. Okay, this is what I think, instead of for the low-grade lesions, for the people that whether they have 10 years to live, plus, and you don't want to be very aggressive with them, or people that just say, what, I read a lot about prostate cancer, this stuff's not going to kill me, I just want to watch it. By default, I put them into this category, and there, every 3 months, you get a PSA, you do a biopsy. Recommendations are various schools have their own protocols, but usually it's either once a year or once every 15 months or something like that. So usually for the first year, I'll do it at 1 year. After that, I'll do it, depending.
The biopsy?
The biopsy, yeah. Just to confirm and make sure nothing's changing. Make sure you didn't go from a 6 to a 7. Make sure it's not in just one area, now it's in 4 areas. That's a problem, and just to confirm what we are looking at here also. Once that's done, or if there's a progression to where the patient gets uncomfortable or the doctor does, then you say, all right, time to pull the trigger, and then you treat it, okay? The important thing about active surveillance is, and this I tell this to patients all the time, over 10 years, 80% of patients eventually get treated. But if you think about that, that's let's say they get treated at year 6 or 7, that's 6 or 7 years where they had their current quality of life, where you're worried about overdiagnosis and overtreatment, you're worried about what it's going to do in the long run. I'm okay with watching prostate cancer as long as I know what I'm watching. If it's something that's changing before your eyes, you have to be sure that you know when it changes, and if you watch it closely, you can really do it and pull the trigger when you need to, instead of just sitting back and just not really doing much, which can be dangerous. That's when if you don't respect the disease, it's going to come back and bite you, and that's really the issue there. Besides that, there's radiation treatment, there's surgical treatment. You can freeze it. You can go to the Bahamas and burn it. That's not something that's FDA approved in America is HIFU. There's also proton therapy, which is another type of radiation. Pretty much the trends on treatments that for prostatectomy, robotic is the way to go now. That's I think I was after that paradigm shift where I'd say I think we didn't do too many open prostates. Let me put it that way. It was all robotic at that point. Even through this was 6, 7, 8 years ago, and that's really the trend. It's you have better visualization. My hand is huge. These little hands are 8 millimeters. So you can see better. You can save what you have to save. You can put back and put everything together better. It's not just throwing stitches and saying I think I got it right. It's looking at it and saying this is a good fit. This is a good anastomosis. In town we have great robotic surgeons, and that's really what it's about.
So that is the standard of care now.
They're equivalent. So radiation and surgery are are equivalent. For standard of care, either of those is acceptable for treatment. Okay, so it's and they're equivalent rates of success. From a surgical standpoint, robotic would be the way to go, unless you're going to, you know, the chairmans at some of these departments that have done thousands and published thousands of papers, and you know. But if you're going to, you know, your regular urologist, I would definitely push the robot over anything else, and just because of visualization and, you know, understanding what's going on in anatomy and things like that.
Well, why, go ahead, Jim.
If you remove the prostate, right, do you need radiation after that?
It depends. So
if it's spread or not?
If it's spread, if the margins are positive, you can discuss that. So there's different types of radiation after that. There's salvage and then there's adjuvant. So adjuvant therapy means that after surgery, if the pathologist says there's a piece of prostate cancer that's left in,
right,
and it's an aggressive type, and the patient wants to be aggressive, you irradiate it, you know, 3 months later, or 6 weeks later, whatever it is, and then you're killing any area around it, and hopefully it's gone, you know, and you're treated there. On the salvage side of it, you watch your PSA. So after surgery, the PSA should be 0. If it's not 0, then there's some prostate tissue left behind, and you need to be very careful.
Okay.
So there are different points at which you say, okay, maybe it's normal prostate tissue that's there, you know. So you say, all right, we're not gonna irradiate that, you know. So how do you know when at which point something is going on?
Right.
It's usually, and even think of it this way: if you have 2 cells that escaped, it takes a long time for those 2 cells to turn into something that's detectable.
Right.
Okay, so you can initially be undetectable, and eventually need treatment later on. So that's why people cannot say, I had my prostate out, I'm not getting followed anymore.
Right.
That's, you know, that you need to be followed forever, you know, and make sure that everything's okay. The points at which we get worried are 0.2. So if it goes from undetectable or whatever it is, or post-prostate to 0.2, then we say, all right, you know, we're watching you very closely now, and we're considering something. At 0.4, you should get treated, okay, because then your rates are going up of having a bad outcome. Okay, if you wait till 1, that's your rates are worse at having a bad outcome. So anything after prostatectomy, you really need to be careful there. From the radiation side, you know, if it's salvage, then if you hit that point, that's when you're getting salvage radiation. The trends now for radiation in general are for pretty much less collateral damage, less damage to the areas around the prostate, more specific. We have markers now that we can put into patients that have GPS tracking in them, pretty much that links to the system. And if the patient moves, or if your bowels move, your rectum up a little bit, and your prostate moves about 0.5 millimeter, it shuts the machine off. You know, so those things that's pretty much where it's trending to, is
So
to decrease collateral damage.
We really want to thank you, giving us a lot. That's a lot of information.
It is.
You're a fast talker.
Thanks a lot.
So
Thank you.
really thank you for coming.
Thank you.
And,
Thank you for having me.
Yep.
We appreciate it.